to you, as you have requested, about reading the complete blood picture or complete blood count, the same name. And this is very important because this is a very useful test, and it's available always when you are sitting in casualty and receiving an acute case. Then one of the very informative and useful and available investigation is the complete blood picture. So let's go to the first slide, please. Next slide. لا محمد روح للسلايدات اللي قبلها، هذه اللي حكيت لك مو نعم. Yes. Okay. So this is the form usually you receive with the complete blood picture. And here I want to remind you that we have three main components in the blood. These components are the hemoglobin, the RBCs, red blood corpuscles, the white blood corpuscles, and the platelets. These are the main ones. سامعيني يا شباب؟ Okay. Yeah. Okay. So this is what you get, and of course the most common abnormality is anemia, and anemia, of course, is reflected by a low hemoglobin. And you must have in your mind a system of reading the complete blood picture. And I will tell you my system. The way I read the complete blood picture is that immediately I look to the hemoglobin. Here you have the hemoglobin on top. Not always, sometimes the hemoglobin in the middle. But look to the hemoglobin, and this slide is showing the normal values, the normal values for male and female, and I hope that you all know the normal values for male and female, but anyway, it should come on the form. Okay, so always look to the form because there is usually a slight variation from one lab to the other. And then you get the white blood cells and the platelets. These are the main three. Okay, when I see a patient with low hemoglobin, I immediately look to the other components. The second component is the white blood cell. If the white blood cell is low and the platelet is low and the hemoglobin is low, then this is a what shall I call it? Inefficient bone marrow, aplastic anemia, or a better term, hypoplastic anemia. And there are causes for hypoplastic anemia, but this is a generalized picture. If I find that the white blood cell is very high, then this could be leukemia. If I find that the white blood cells are normal, the platelets are normal, and the hemoglobin is low, then this is an easier problem. Here the problem is only in the hemoglobin. This is only anemia, and the other components and the bone marrow most probably is normal. So what I will do, go to the next slide, please. Yes, this is an example. You see the hemoglobin here is 9.6. This is low, okay? So this is a moderate anemia, not very severe anemia, a moderate anemia. Then I look to the white blood cells, and the total white blood cells is with the normal limits. And I look to the platelet. The platelets are high, a little bit high, 840, okay? So this picture, we will discuss it later, but this is suggestive of iron deficiency, because in iron deficiency, often the platelet count is normal. I look to the MCV here. The MCV here is on the low side, but it's still within the normal limit. But the possibility of iron deficiency is there. But we will talk about this later when I'll talk about other types of anemia. محمد من فضلك روح للسلايد يمكن رقم 4 أو 5. مع الأسف هذه السلايدات ما جت in order، فارجع للبرزنتيشن الأصلي. اللي بعده وبعدين راح نرجع على ذني اللي بعده خليك هنا. Okay, this is a very important slide which I want you to be familiar with. When we decide that the problem is only anemia and the other components of the blood are normal, the white blood cells and the platelets, then this is a problem only, as I said, only with the RBCs. And here we classify anemia into 3 classes: microcytic, macrocytic, and normocytic. Okay, and this is very important. What is the measure? How do we measure the size of the RBCs? Of course, microcytic means micro means small in Latin, and cytic means cell, and macro means big cell, and normo means a cell of normal size. Okay, and this is a very useful classification, although there are other types of anemias of classifications, but this is the famous one. Okay, now Muhammad, please go to the first slide. Go up. Yes. This is an example. We will come to this example. But this is a common question for data interpretation, a very good question for data interpretation. The question says, a 25-year-old female, Cypriot. And here they refer to this. Cypriot means قبرصية, من قبرص. And as you know, قبرص is from the Mediterranean, حوض الأبيض المتوسط. Thalassemia is common in this area. In this area. It's extremely rare in Europe and North America. Okay, this 25-year-old female Cypriot complaining of tiredness, and her hemoglobin is 10.5. Okay, so what do we call this 10.5? I call this 10.5 as mild anemia. Now, in this particular patient, the white blood cells normal and the platelets are normal. So what I do, I go to the MCV. The MCV means mean corpuscular volume. This is the volume of the red blood corpuscles. Okay, and the MCV in this particular patient is 65. This is low. Okay, so this is microcytosis. So this anemia is microcytic anemia. Okay, the MCHC main concentration of hemoglobin is 32 with the normal, and the RDW, and I will come to this later, is with the normal limits. As you can see, the figure is 12 and the normal is 10 to 14. So what are the possibilities? This is microcytic anemia. There are two common possibilities. One is iron deficiency anemia. Remember that in iron deficiency, the first thing to go wrong is that the red blood cell will get smaller in size. So microcytosis is the first morphological manifestation of iron deficiency. And if microcytosis does not compensate for the degree of iron deficiency, then hypochromia will occur. Hypochromia means less hemoglobin. Okay, so that's why the name is microcytic hypochromic. Okay, call it this way. Don't say hypochromic microcytic. No, microcytic hypochromic. This occurs in iron deficiency anemia, but it occurs in thalassemia as well. And now we will know how to differentiate between iron deficiency anemia and thalassemia. And this is very, very important because patients with thalassemias are often iron overloaded. And if you make the mistake of treating them with iron as iron deficiency anemia, then you may do a lot of harm because iron is a heavy metal and it is likely to get precipitated in organs like the liver, causing liver cirrhosis, and the heart causes cardiomyopathy, and the pancreas causes diabetes, and the skin increasing pigmentation, etc. Next slide, please. The next slide is how do we analyze the case and how do we further our investigations, okay? So what's said here in the next slide, microcystic anemia, and we did say this. What is the possible diagnosis? The possible diagnosis, number one, is iron deficiency anemia. Number two is thalassemia. And we do, of course, other tests, but before that, in the history, you have to clarify which is which. For example, here in this case, he said that the patient is Cypriot, and this is a clue that it may be thalassemia. Okay, but again, it's your duty in the history to ask about diet. Okay, because as you know, iron, and you have to know iron metabolism very clearly. A normal balanced diet contains about 10 milligram of iron. This is per day. This is what you people take, okay? And iron metabolism is maintained mainly by absorption. And this is applied to iron. It doesn't apply to some other nutrients. We will come to this later. So iron is absorbed in the upper gastrointestinal tract, mainly in the duodenum and jejunum. Please remember this. Iron is absorbed in the duodenum and jejunum. As I said, 10 milligram, usually you take in your diet about 10 milligram per day, and the body absorbs 10 to 15% of this according to the need of the body. So if the patient is iron deficient, then absorption will increase, but just a little bit, not very much. If the patient is iron overloaded, then absorption will be decreased, but again, just a little bit. Okay, this is what your human body can do. Okay, so if you give too much iron, you can overload the patient with iron, as I said, and this can get precipitated in organs and causes many problems. Okay. Then the question here, if we absorb 1 milligram daily, so iron will accumulate. No, iron will not accumulate because we lose usually about the same amount, 1 to 1.5 milligram of iron daily, mainly by shedding gastrointestinal mucosa. You know, the mucosa of the stomach doesn't live more than 2 weeks, okay? And with the shedding of the mucosa, the body will lose some iron. There is additional loss of iron in among females, and this is mainly by menstruation, by pregnancy, and by breastfeeding the baby. Okay, all these can deplete iron. That's why the hemoglobin usually a little bit lower in females, and iron absorption a little bit more. So a female absorbs about 15% of the dietary iron, which is 1.5 milligram, and she loses the same amount, while a male absorbs 10%, which is 1 milligram of iron in the diet, and he loses about the same amount. investigation-wise, we have to further our investigation, and the most important test in this patient is the serum ferritin. Okay, the serum ferritin in this particular patient, the female from Cyprus, is 50, which is within normal. So the patient is not iron deficient. Of course, here the serum ferritin is an acute protein of reaction, and if there is inflammatory process, the ferritin may go up. Okay. And if there is a protein deficiency, it may go down. But for practical reasons, the serum ferritin is a very good predictor of the status of iron deficiency. So in this patient, the ferritin is normal. So what is the possibility? Iron deficiency or thalassemia? The possibility is thalassemia. And how we can document the diagnosis of thalassemia? We can document the diagnosis of thalassemia 100% by doing hemoglobin electrophoresis, and in the hemoglobin electrophoresis, as you see here in this slide, the hemoglobin A2 is raised 5%, and this confirms the diagnosis of beta thalassemia. Next slide, please. Okay, so you may ask here, what's the treatment in case number 1? The treatment is reassurance. This is a genetic disease. The 10.5 gram of hemoglobin is not too bad, and because it's a chronic process, so usually the patient's body compensates very well, and probably the symptom is related to something else. So what they need assurance, and of course you have to advise them not to marry their relatives, because if this lady, which has beta thalassemia, marries a man from her cousins and he has beta thalassemia as well, the children may have the gene from both sides, and then they will have a severe form of the disease. Okay, case number 2, a 70-year-old Caucasian male, Caucasian means European or North American, complaining of recurrent mouth ulcers, and his hemoglobin was found to be 10, and the MCV is 105. Okay, the white cell is 2.1, the neutrophils 0.5, and the platelets 120. Okay, look to these. Number 1, the hemoglobin is 10, and again, this is anemia, not severe anemia, this is mild anemia. The MCV is 105, this is high. So what do we call this? We call this macrocytic anemia. The white cell is low, 2.1. The platelet is a little low as well, 120. This is, as a matter of fact, this is typical of B12 deficiency. In B12 deficiency, usually the not only the hemoglobin will go down, but the platelet will go down, and the white blood cells will go down as well. So B12 deficiency can cause, and folate as well sometimes, can cause a picture which is just like hypoplastic anemia. Hypoplastic is a better term than aplastic anemia, because A means no, but hypo means low. Okay, next slide, please. Okay, so this is macrocytic anemia with pancytopenia. Further investigation, check the blood. Okay, and here in this part, is A. Okay, so it is within normal, are normal, the stimulating hormone is normal. And here is a question: why did the because, as I said earlier, the folate can cause macrocytic anemia just like B12. Okay, you have always in your mind to have a list of causes of all types of anemia, and the commonest two types of macrocytic anemia are the folate deficiency and B12 deficiency. Liver function, the liver function test was requested, and here it was normal because liver disease can cause macrocytic anemia as well, okay, and TSH as well, hypothyroidism. Thyroxine is important, is required for the RBC formation as well, so it can cause anemia as well, and the anemia of hypothyroidism is usually macrocytic. The reticulocyte count in this particular patient is 25, which is high, okay, and this is indicate hemolysis, mild degree of hemolysis, and this is common with B12 deficiency, because in B12 deficiency, immature RBCs will be released and they will get hemolyzed. Okay, so this is called ineffective erythropoiesis. Next slide, please. Okay, this patient, this is a blood film and bone marrow for the same patient. B12 was given, and a bone marrow was done, and the bone marrow showed myelodysplasia. Next slide, please. This is, we have seen this slide before. This is a classification of anemias. I remind you again, the anemia may be microcytic, macrocytic, or normocytic, and I will say this should always be the first question you ask yourself: what type of anemia is this whenever you find an anemic patient? Next slide, please. Full blood count here. The name for this test is full blood count, or sometimes you find it complete blood count. So FBC or CBC is the same. Okay. The anemia, the hematocrit PCV, if high, it indicates polycythemia, and anemia, it's low in iron deficiency and thalassemia, as we have discussed this before. Right blood indices, the MCV is very important, and the others are MCH, mean corpuscular hemoglobin, and the other one, mean corpuscular hemoglobin concentration, and the RDW, and I'll come to the RDW later. Next slide, please. Yes, this is the red cell distribution. Well, this is the RDW. What it indicates, it's positive in this patient, it indicates that the red blood cells are of different sizes, okay? They are of different, some of them are small, some of them are medium in size, and some of them are big in size, and this can be measured by the automatic analyzer. Okay, and this variation, the other term for it is anisocytosis. Anisocytosis, and N means none in English. Iso means size. Cytosis means cell. So this means that the size of the red blood cells are different. They are not equal. Okay, anisocytosis. Okay. This increases in iron deficiency, and it remains usually with the normal limits in thalassemia. We did say that iron deficiency and thalassemia, both of them cause microcytic anemia, okay? But in iron deficiency, the RDW is usually high, while in thalassemia it remains with the normal limits, but the diagnostic value of this test is not very high. The serum ferritin has a much higher diagnostic value. Okay. Normal in thalassemia, normal in chronic diseases, can be very high in megaloblastic anemias. Yes, can be very high in megaloblastic anemias, and we will discuss this. Yeah. Next slide, please. Now, microcytic anemia. It could be iron deficiency, it could be thalassemia trait, it could be anemia of chronic diseases. But usually the anemia of a chronic disease, rarely microcytic. Usually it's normocytic, but still it could be microcytic. So how do we differentiate between these three? In iron deficiency, the serum ferritin, of course, in all these, remember, the hemoglobin is low and the MCV is low. So when the MCV is low, we call it microcytic anemia. In iron deficiency, the serum ferritin is low. The serum iron is low. And the TIBC, total iron binding capacity, is high. And here, I must discuss this. Sometimes I see that some doctors request serum iron. You shouldn't do this. Whenever you request serum iron, you should request total iron binding capacity with it. Why? Because normally 1/3 of the TIBC, total iron binding capacity, is saturated by iron. In states of iron deficiency, the serum iron will go down and the TIBC will go up. So the difference will be high. In states of iron overload, the serum will go up and the TIBC will go down. So the difference will be closer. What I'm saying here, what do I mean? In iron deficiency, normally it is 1/3. 1 for serum iron, 3 for TIBC. In iron overload, it may be 2 to 3. 2 for the serum iron and 3 for the TIBC. In iron deficiency, the serum iron is the gap is bigger, the serum iron is lower, and the TIBC is much higher. This is the serum iron low, TIBC, so it may be 1/6, 1/8. This indicates iron deficiency. But I must say this here again. If serum ferritin is available for you, request serum ferritin only. If it is not available, then request serum iron and total iron binding capacity, request them together. Yes. In thalassemia, the serum ferritin is normal and the hemoglobin A2 is usually raised. And if you remember, in the first case, the hemoglobin A2 was 5%, which is high. Of course, the 5% in the first year of life could be normal. Okay, but later on, the fetal hemoglobin will go down. So in an adult, a hemoglobin A2 of 5% is high. In anemia of chronic disease, the serum ferritin could be normal or raised. Okay, it's not usually low. So this is a differentiating point. The TIBC, total iron binding capacity, is usually low, and the ESR or the C-reactive protein are high, indicating an inflammatory process. Okay, next slide please.
دكتور بس سؤال هنا قبل
تفضل.
دكتور ليش بالانيميا وكرونيك ديزيز صار التي اي بي سي also low؟
الTIBC also low. there's no explanation for it. Not everything is explained. Okay, but this is look. What it means, the TIBC, it means the ability. شو الصوت صار دبل محمد، من فضلك سكر شو اسمه من عندك، سكر السبيكر حتى تسمعني أوضح. What the answer to your question, Muhammad, which is a very good question, is the TIBC will go low because the TIBC, what does it mean? It means the ability of the albumin to bind iron. In chronic diseases, this is lower. Because of the chronic inflammatory process, this is lower. Okay.
اوكي شكرا دكتور.
ما اعرف اذا جاوبت سؤالك يعني على الجسم، but this is a fact of life. Any other question up till now? Okay, let's go to the next slide, please. I think we have discussed most of the points in this slide earlier, okay? But I'll leave you for a few seconds just looking at the slide. This slide show you the differences between iron deficiency and thalassemia trait. Next slide, please. Yes, and this slide, usually the slide on the right-hand side, this is a blood film of thalassemia, and on the left-hand side you have a blood film of iron deficiency. You see both slides showing hypochromia. Both slides showing red blood cells of small size. Okay, but you can see in iron deficiency there are different forms of RBCs, pencil cells, very small microcytes, hypochromia sometimes very severe, while in thalassemia most of the red blood cells look like each other. That's why the LDW, which I have discussed earlier, is usually high in iron deficiency and it's within normal limits in thalassemia. But this is a blood film, and an expert technician can tell you that this is more likely. The report of the technician in both cases will be microcystic hypochromic anemia, but he may suggest that this is more likely to be iron deficiency or this is more likely to be thalassemia. By the way, there is another way which is very practical. I usually myself do it. In differentiating between thalassemia and iron deficiency, I usually go to the previous notes of the patients, okay? And we'll see that a thalassemia patient from the age of 2 years and above 1 year, because in the first year, the hemoglobin is usually normal. But after the first year of life, because this is a genetic disease, you will find that the hemoglobin is always low. While in iron deficiency, the hemoglobin could be normal for, say, a 16-year-old girl. But because she started menstruating, then the anemia goes down. Okay? Next slide, please. The hemoglobin goes down. Next slide, please. Iron deficiency, always confirm with ferritin. Yes, always confirm with ferritin. We discussed this. We said maybe falsely normal with active disease. Yes, in acute or chronic diseases, but usually here you will have the picture clear. For example, a patient with active rheumatoid arthritis, anemia, microcytic anemia, suggestive of iron deficiency, but the ferritin is within normal. We will say this is acute phase reaction. Acute phase reaction means that the ferritin is high because of the inflammation, not because it's actually high. Actually, it's low because iron deficiency, but the inflammatory process causes increase. Okay. If the ferritin is more than 50, then iron deficiency is less likely. Yes, an early deficiency or with mixed deficiencies, the MCV may be normal. This is an important point which I want you to pay attention to. Iron, as I said earlier, is absorbed in the duodenum and jejunum. These are the first parts of the small bowel. Are you familiar with the anatomy of the gastrointestinal tract? Yes? Yes. Okay.
Yes.
Okay.
Yes.
Okay. Folate is absorbed in the same place. Folate again is absorbed in the duodenum and jejunum. Iron deficiency causes microcytosis. Folic acid deficiency causes macrocytic anemia. Okay? So remember this. And a very good example of this is celiac disease. Celiac disease is a disease which causes subtotal villus atrophy of the duodenum and jejunum. And this is where iron and folic acid are absorbed. So this patient is very likely to have microcytic anemia because of iron deficiency and macrocytic anemia because of folic acid deficiency. This is called a mixed deficiency. This is called a mixed deficiency. Okay, if you are using the automatic analyzer will give you a normal MCV. Why? Because there's microcytosis and there's macrocytosis, and the automatic analyzer will take the resultant. Resultant means al-khulasa of both, so the MCV may remain normal. Okay, but if a technician is looking or a hematologist is looking to the blood film, he may tell you that this is a dimorphic blood picture. Dimorphic blood picture means, di means two, and morphic from morphology, the shape of the red blood cells, indicating that there is one generation of RBCs, which are microcytic hypochromic, another generation macrocytic hypochromic. The first one is due to iron deficiency. The second one is due to folic acid deficiency. And I have seen it at least once. I remember a very clear case. This picture suggested to me celiac disease. The patient was anemic and the blood film was dimorphic, reported by a technician in my private clinic as dimorphic. I called him to the hospital a few days later, and I took a biopsy from the duodenum, and it was celiac disease, diagnostic of celiac disease. Okay, so remember this. Let's go back to iron deficiency. What are the causes? The causes could be diet, and remember that iron present mainly in meat and dark green vegetables. السبانغ الصبيناغ أحسن شو اسمه والكرفس وما شابه. Dark green leaves are good source of iron, and a better source of iron is meat. Okay. Another cause after the diet, probably the dietary deficiency is the commonest, but a second cause is malabsorption, and probably one of the commonest causes of malabsorption is celiac disease, which I have discussed earlier. A chronic blood loss usually causes iron deficiency. Chronic blood loss occurs mainly from two systems, from the gastrointestinal system, and this is common in males, and from gastrointestinal system and the uterus in a female. So in a male, ask about about loss of blood, signs and symptoms of loss of blood through the gastrointestinal tract, like melena or hematemesis, or the presence of occult blood, which is a very useful test, occult blood in the stool. And in a female in the reproductive period of life, ask about her menses, pregnancies, abortions, labor, etc. Okay. Next slide, please. Next slide, please. Failure to respond to iron. The treatment of iron deficiency should always be an oral iron. Okay, you shouldn't go for parenteral injectable iron from the beginning, because this can cause a problem. It can cause allergy, particularly type 3 Arthur's reaction, and it's painful as well, while oral iron is tolerated very well by the majority of the patient, but not all of them. Okay, and as I said, when you give oral iron, then increase from the gastrointestinal tract will increase, absorption from the GIT will increase when there is iron status deficiency, and you should give iron for at least 4 months in moderate or severe anemia. Why? Because a normal human body contains about 6 grams of iron. 0.5 gram is circulating in the red blood cells, and 5.5 is stored in the liver, spleen, and other reticuloendothelial systems. When the patient is iron deficient, this means that he or she has depleted the stored iron in the liver, spleen, and in reticuloendothelial system. So you give within about 3 weeks. Most anemias, 3 to 4 weeks, will be corrected back to normal, but you should give oral iron for additional 3 months to restore the stores of the body. Not only this, but if there is an underlying cause, you should treat the underlying cause. If there is a gastrointestinal loss, you have to treat, endoscope and treat. In the case of heavy menses or something, refer the patient to a gynecologist for a treatment. Okay. Poor compliance, the patient is not taking the tablet. Another cause, intolerance due to side effects. Some patients may develop anorexia, sometimes constipation, as a side effect of iron, and in this case, injectable iron may be given. Next slide, please. Yes, these are the examples of injectable iron. There are many forms available. Some of them can be given intramuscularly, some others can be given intravenously. You have to go to the BNF, British National Formulary, this pharmacology book, very useful book, whenever you want to give injectable iron, because you have to count it according to body weight and to the degree of anemia. Next slide, please. Increased ferritin. What are the causes of increased ferritin? We did mention earlier a chronic inflammatory process, chronic liver disease, particularly alcohol-related. Actually, alcohol not only increases the ferritin, it increases iron, because iron will be absorbed more from the gastrointestinal tract. This is the main mechanism. Plus the fact that some of the alcohol, some types of alcohol are stored in iron barrels, so they contain a big amount of iron, and in these cases, iron will get precipitated in organs like the liver, the heart, the pancreas, as I said earlier, the skin. Malignancy is another cause of increased ferritin. Repeated transfusion, yes, this is particularly common in chronic severe hemolytic anemias like thalassemia major, not thalassemia minor. Yes, hereditary hemochromatosis, another cause of very high, usually serum ferritin, and usually these patients present with organ damage like the liver, the pancreas. Yeah, porphyria is another cause. Blood transfusion, repeated transfusion is a cause. Next slide, please. The third case is a 65-year-old Caucasian male. He is non-stable mild CLL. CLL is a chronic lymphocytic leukemia. A chronic lymphocytic leukemia, and he is on no treatment. And here is a question which crosses your mind. If the patient is suffering from chronic lymphatic leukemia, can we leave him without a treatment? Yes. If the count is not very high, 20,000 or below 50,000, and there is no bleeding, then this is a disease which is compatible with long life, and usually it affects people. It affects elderly people. So if you have a patient who is 80 or 82 years old with mild chronic lymphatic leukemia, you just follow him up. And as I said earlier, no active treatment is required, but there are some indications for a treatment. Like one of them has developed in this patient, and we will come to this. This patient recently started complaining of increasing fatigue and breathlessness. Okay, and he was found to be jaundiced. This is an important symptom and sign. The symptom is the fatigue and the breathlessness, which indicates anemia. And the second one, jaundice, which indicates that the anemia is probably due to hemolysis, because as you know, what hemolysis will do, it will split the RBC, bilirubin and heme, and the bilirubin will go high, and the patient may present with jaundice, but usually the jaundice of hemolysis is usually very mild, and it's described always as a lemon tinge. Lemon tinge, لون النوم الحامض الليمون. Lemon tinge in the sclera is not usually a moderate or severe jaundice. A moderate jaundice is usually orange in color. It can affect, in addition to the sclera, the skin, and this is characteristic of hepatocellular jaundice. And deep jaundice is characteristic of obstructive jaundice. And deep jaundice is usually orange, greenish in color. Okay, when you will have some experience, sometimes on a clinical ground, you can tell which type of jaundice is this, because we have three main types: hemolytic, hepatocellular, and obstructive. In this patient, the patient was jaundiced. There was no enlargement of lymph nodes or spleen. And what does this mean? In a patient with a chronic lymphocytic leukemia, there is no lymph node or spleen or liver. It indicates that this is not a relapse of the disease. Okay, this is due to hemolysis. This new symptom is due to hemolysis rather than due to relapse. Because can the disease relapse? Yes. Rarely it can even go to a blastic form. So it can change from chronic lymphocytic to acute lymphoblastic leukemia. Okay, which is a terminal phase. But in this phase, no, it is not deterioration of the leukemia itself, but it is one of the complications, and we will further our investigation to see whether it's our suspicion is hemolysis, to see whether it's hemolytic or not. So go to next slide, please. Yeah. In the next slide, we checked the complete blood picture of the patient, and what we have seen a hemoglobin of 8, which is moderate anemia. The MCV is 102. The MCV is high. And does this go with hemolysis? Yes. Why it goes with hemolysis? Because with hemolysis, the RBCs will be destroyed quickly. So the bone marrow will throw in the circulation thromboblasts. And the thromboblasts are in the immature red blood corpuscles, and they are bigger than a mature red blood corpuscle. You must know this from your histology. So the MCV will be high. The white blood cell in this patient is 30. And the 30 is high, but not very high for a patient with a chronic lymphocytic leukemia. So it is not an exacerbation of the leukemic process. It is the hemolysis, the complication. The lymphocyte 25, platelet count 300, bilirubin is 60, and a high bilirubin with anemia, as I said earlier, indicates that the anemia is probably hemolytic. Okay, the reticulocyte count in this patient is 300, which is very high, very high. And the reticulocytes are, normally they are 1 to 2% in the circulation. To replace the red blood corpuscles, as you know, a red blood corpuscle survive 100 to 120 days, and then it gets replaced. So in actual fact, there is a continuous process of hemolysis in a human body, but we don't call it hemolysis because it's physiological. Okay, so when a red blood corpuscles lives for 100 days, this means each day we have to replace 1% of our red blood cells. So the reticulocyte count normally is 1%. If they live for 120 days, then each day we have to replace 0.8% of our red blood cells. That's why the reticulocytes, which is the immature red blood cells, normally is 0.8 to 1%. In this particular patient, it's 300, which means it is very high. This means that the bone marrow, because of the anemia, is trying to produce more red blood cells, but they get destroyed early. So the reticulocyte count is high. The LDH, this is an enzyme which is present inside the RBC, is very high in this particular patient. It's 900. Normally it should be below 450. So in this patient, it's double or a little more than double, which indicates continuous destruction of red blood cells. Conjugated bilirubin is 10 is high. And the last test is the Coombs test, which is diagnostic in here. The direct Coombs test was positive in this particular patient. It indicates hemolysis, and the treatment of this patient is not by increasing or by giving anti-leukemic treatment. No, the treatment here is corticosteroids, and usually they respond in a very good way to corticosteroids. Next slide, please. Yeah, the diagnosis macrocytic anemia, macrocytosis used to increase reticulocyte, and I did explain why the reticulocyte is increased because of more destruction of RBC. So the bone marrow will try to replace the destroyed RBCs, and a reticulocyte is bigger in size than a mature red blood corpuscles. That's why the MCV will go high, and this is reflected as macrocytosis. Hemolysis causes jaundice. Yes, hemolysis, autoimmune, positive. We discussed this. And the treatment, the last point, the treatment is a steroid. Prednisolone, usually 20 milligram twice daily. And then we taper the dose gradually. This should be discussed in a separate lecture. Next slide, please. What test do we do for hemolysis? Yeah, we have been through the test. First of all, you do a complete blood picture when hemolysis is suspected. Then you do liver function test. the bilirubin, you check the reticulocyte, which is usually increased. You check the enzyme LDH, which is usually increased. The haptoglobin is usually low, and this is another useful test. A blood film will show polychromasia. Polychromasia means different colors. Poly means متعدد. Okay, and the chrome color متعددة الألوان. Spherocytosis or sickle cell, these are two types of chronic hemolytic congenital inherited hemolytic anemia, and these are usually easily diagnosable on a blood film. Okay, hemoglobin electrophoresis is diagnostic of these conditions, and a direct antiglobulin test is diagnostic of autoimmune hemolytic anemia. In these anemias, spherocytosis and sickle cell anemia, which are inherited congenital, the Coombs test is negative. But in acquired hemolytic anemia, like the anemia we discussed in this particular patient, CLL, chronic lymphocytic leukemia, the Coombs test is usually positive. Next slide, please. Yes, this is a blood film of two patients. The first one on the right-hand side is spherocytes. You see they are small. There are many RBCs which are smaller, and hence the term spherocytosis. The other slide, the sickle cell. Okay, sickle, means المنجلي. Next slide, please. What are the causes of macrocytosis? Again, we have discussed this: B12, folate deficiency, chronic liver disease, excess alcohol, very common in the West, and myelodysplasia. Less common, hemolysis, myeloma, other bone marrow disorder, and hypothyroidism. Again, I have said this, thyroxine is required for the formation of RBCs, and in thyroxine deficiency, hypothyroidism, the anemia is usually macrocytic, not microcytic, macrocytic. Next slide, please. Yes, this is what we mean by polychromasia. The slide on the right-hand side, you see that the RBCs are different in shape and in colors. Okay, and on the left-hand side, this is characteristic of the target cells in a chronic liver disease. Target, you know what's target? Target means هدف. يخلون هدف ويرمون عليه target. Next slide, please. B12 and folate deficiency, both of them can cause megaloblastic anemia. Megaloblastic is a bone marrow term. Macrocytic is a blood film term. Okay, so anemia could be macrocytic, but not necessarily megaloblastic. Okay, but the megaloblastic anemia is usually macrocytic. Okay, here in this slide, you see the oval macrocytes and poikilocytosis, and in the other slide on the left-hand side, you see hypersegmented polymorphs. You can see the hypersegmented in the center of the slide, and another one at the lower part of the slide. Yes. Next slide, please. This is a megaloblastic bone marrow. Okay, next slide, please. Megaloblastic anemias, we have discussed this. Usually the hemoglobin is low and the MCV is usually very high, above 100, and the RDW usually is high. With severe anemia, you can see poikilocytosis and isocytosis, either cytopenias, film hypersegmented polymorphs, which we have seen earlier in the previous slide, and the LDH is high. Why the LDH is high in in megaloblastic anemia like B12 deficiency, because we said these cells will break down quickly. Okay, and the LDH is an enzyme which is present inside the cells, so it will be released in the circulation, and the LDH will go up. So LDH is very high in hemolytic anemia and moderately high in megaloblastic anemia. In megaloblastic anemia, we use the term ineffective erythropoiesis. Ineffective erythropoiesis means that the red blood cells are formed, but they are destroyed early before they finish their life expectancy, which is, as I said earlier, 100 to 120 days. Okay, and usually in megaloblastic anemia, because of ineffective erythropoiesis between two brackets, mild hemolysis, the bilirubin is usually slightly increased. Next slide, please. B12 deficiency, the levels vary, but there is a recent study which showed that if you find the B12 on the low border, please treat because most of these patients are deficient. Okay, deficiency are more common among vegetarians because B12 usually is taken from animal products, mainly meat. Okay, and the liver. Okay, the MCV is usually high. The patient earlier may be not anemic. They may often present with high MCV, and B12 deficiency can cause a neurological symptom, and it can cause macrocytic anemia. And the neurological symptoms sometimes present alone without the anemia. Okay, and this is often called posterior degeneration of the posterior column. In your neurology, probably you will see this. The patient will lose the vibration sense if you have done a neurology, and the joint position sense on examining the peripheral extremities. Yeah. Dementia is another manifestation of B12 deficiency, and as a matter of fact, all patients with dementia or what look like an Alzheimer disease, okay, a forgetful old man or woman, in these patients always the B12 must be checked. Okay. Levels can fall in pregnancy, and in pregnancy not only the B12 can go low, but the hemoglobin can go low. The white cell can be low, the platelets can be low. Why? Because the volume of blood is increased. And actually, when we measure the hemoglobin, we are not measuring the absolute amount of hemoglobin in that human body. No, we are examining the amount of hemoglobin in a particular volume of blood. So if the volume of blood is diluted more, is increased, and the volume of blood is at least 25 to 40% more in a pregnant woman in the third trimester of pregnancy, so the hemoglobin will go down. Okay, yeah. Schilling test is not important, but you have to look for another causes of B12, and a trial of giving B12. B12 can be given by injection, and it can be given sublingually. The main store for the B12, you must know this, is the liver. A normal liver contains about 3 milligrams of B12, and the daily requirement is about 5 micrograms. So the 3 milligram can take you for a very long time, about 2-3 years before getting deficient. B12 is taken again, as I said, from animal sources, mainly meat, by the mouth. You must know the physiology of this. In the stomach, it will get combined with intrinsic factor, and then it will pass and it will get absorbed in the ileum. Okay, so stomach disease can cause B12 deficiency. Okay, these are the normal figures. Have a look at them. Next slide, please. Yes, folate deficiency. Again, I leave you having a few seconds looking at this slide. Yeah, the last point, think of malabsorption, celiac disease. We have discussed this earlier. Next slide, please. Isolated macrocytosis, consider GGT. This enzyme is highly suggestive of alcoholism, which is very common in the West, in Europe and North America. The commonest cause of high MCV is alcohol intake. Yes, chronic liver disease is another cause. Pregnancy is another cause. Myelodysplasia rarely can cause this. And the drugs, particularly cytotoxic drugs, hydroxyurea, methotrexate, and azathioprine. All these drugs are in use. We often use them, and all of them can cause macrocytosis and MCV above 100, above 120. Next slide, please. Case study number 4, a 60-year-old Caucasian male complaining of shortness of breath. The hemoglobin is 9, the MCV is 88, the white blood cells and the platelets are normal. You see, this is all the hints I have told you before. When I see the hemoglobin, I look immediately to the white cell and the platelet. The white cell and the platelet are normal, so it's probably not a bone marrow problem. I go to the MCV to see whether this is microcytic, hypochromic, or normocytic. The MCV here is 88, so this is a normocytic anemia. Normocytic anemia because the MCV is with the normal limits. Next slide, please. In this patient, we have to further our investigations by doing other blood tests. The thyroid stimulating hormone, TSH, in this patient was normal. The LFTs was normal. The ESR is 30, a little bit high. The creatinine is high. So this indicates a chronic kidney failure, chronic kidney failure. And as you know, remember probably from your physiology, RBC formation is controlled by a hormone secreted mainly by the kidneys called erythropoietin. So when the kidneys are diseased, not an acute disease, but a chronic kidney failure, chronic renal failure can cause anemia. And in this particular patient, the erythropoietin was low. Okay, so the diagnosis is anemia secondary to chronic renal failure, and the treatment is erythropoietin and injectable iron. This needs some experience in treating these patients, but usually what usually do, I start with injecting erythropoietin, usually about 4,000 international units twice a week with injectable iron until the hemoglobin is is acceptable, around 9 or 10 grams. This is, we consider it acceptable. Then we may titrate the dose, go with the dose a little bit lower. Instead of twice or 3 times injection a week, I may go down to once weekly injection for the rest of the patient's life. Or if the patient undergoes kidney transplant, then we can probably sometimes stop the erythropoietin. Next slide, please. Normocytic anemia is non-specific. Most of the blood test, hematology tests will be normal. Sometimes it occurs with iron deficiency, combined deficiencies, the dimorphic blood picture, which occurs mainly with celiac disease, I have discussed earlier, because of macrocytic generation and microcytic generation, but only the automatic analyzer will make this mistake by giving you a normal MCV. But if you examine the blood film, you will see 2 generations of red blood corpuscles. Recent bleeding is another cause. Anemia of chronic disease can be microcytic, yes. Next slide, please. Anemia evaluation. How do we evaluate anemia? We have discussed this. Okay, I'll give you a few seconds to look into this slide, but all these patients I have discussed earlier. Next slide, please, yes. Functional anemia. What do we mean by functional anemia? Increased loss, acute. If it's acute, this will cause hypovolemia. If it's a chronic, then it causes iron deficiency anemia. The typical blood loss which causes iron deficiency anemia is secondary to drugs like aspirin, which causes gastrointestinal bleed, or any lesion in the gastrointestinal tract like hemorrhoid, a polyp, or carcinoma of the colon or stomach, etc. Increased destruction, this is hemolysis, and we have discussed this. Decreased production means bone marrow failure. And bone marrow failure, we have seen one case due to erythropoietin deficiency. The previous case I have shown you in chronic renal failure because the erythropoietin is low, but the bone marrow itself is normal. So we give erythropoietin and the hemoglobin will go up. But the bone marrow can be affected by many diseases like myelofibrosis, which causes fibrosis of the bone marrow. Carcinomas can metastasize to the bone marrow and destroy most of the bone marrow, and this can cause hypoplastic anemia. And sometimes hypoplastic anemia is idiopathic. Idiopathic means no obvious cause. Next slide, please. Alhamdulillah. Okay, so this is the end of part 1. تعبتوا يا شباب ولا
لا زين؟
زينين؟ اوكي. كم واحد معانا؟ كم مشترك؟ زملائك كم عددهم يا محمد؟ محمد تسمعني؟ Here's the patient. Okay, because if you go to some textbooks, they'll say if it is below 7 transfuse. I don't agree with this because anemia is usually, particularly iron deficiency anemia, is usually tolerated very well if it comes gradual. But if it is acute, then the patient will complain much. So if it is gradual and the patient is not in a bad shape, I'll treat with iron, and you will see once you start the patient on iron, he'll improve. They say once the serum iron is a little high, then even before the anemia gets corrected, the patient will feel better in himself. Okay, and you give oral iron, as I said, for a few weeks to correct the anemia, and for additional 3 months to restore the storage of the body.
اوكي دكتور زين منو الافضل يعني which is better البارنترال ولا الاورال يعني؟
وهذا اللي نقول الاورال is easier, there is no side effect etc. والبارنترال يعني I did show you a slide indication for parenteral. So the usual treatment is oral. But if the patient has untreated celiac disease, this means that he, although in celiac, you must put the patient on a gluten-free diet, and with a gluten-free diet, within a very short time, the villi will replenish itself again, and then you can give oral. But if not, if the patient is non-compliant, injectable, if the patient cannot tolerate oral iron, some patients develop constipation or diarrhea or nausea and vomiting from oral iron, then you can give parenteral iron. The other indication for parenteral iron is chronic renal failure. When you treat with erythropoietin, and again, I have discussed this in the lecture.
اوكي دكتور بس سؤال ثاني
تفضل
دكتور.
تفضل حمد.
تفضل.
Doctor, but I have a question about erythropoietin. You said there is clinical adjustment to give erythropoietin in chronic kidney disease.
Yes.
Could you explain that? What is the indication?
Yes. I will. This is a very good question. If you go to your textbooks, then they will say in chronic renal failure, actually in chronic renal failure, almost always the hemoglobin is low. And usually this anemia is tolerated reasonably well by patients, but it requires a treatment because it was found that survival in chronic renal failure increased if you correct the anemia. How do we correct the anemia? We correct the anemia, first of all, by knowing the type of anemia. So the commonest cause of anemia in a chronic renal failure is not erythropoietin deficiency, is in actual fact iron deficiency. So you check the serum ferritin, you check the folate, you check the B12, you treat accordingly. If these are normal and the erythropoietin level is low, so this is due to the fact that erythropoietin is low. Here you have to treat with erythropoietin injection with injectable iron. We give usually 4,000 international units, but it's according to body weight. You can go to the leaflet on the drug and you go, but the usual dose is 4,000 international units, 2 or 3 times weekly, until the hemoglobin is reasonably well. And what is a reasonable hemoglobin? The old textbook will say 9 to 10 grams, but recent studies will say no, go further, 10 to 11, and I believe 10 gram per 100 is still a mild anemia, but better than the 9 grams, okay? So you give erythropoietin in this dose, and once the patient, you give erythropoietin, say, twice weekly or 3 times daily, until the hemoglobin is between 10 and 11, then reduce. Instead of 3 times, go to 2 times, or instead of 2 times, go down to 1 time weekly, and you have to maintain your patient on this dose for the rest of his life, unless he has kidney transplant. If the patient later treated with kidney transplant, then he will have a normal hemoglobin, a normal erythropoietin, and the hemoglobin will be corrected. Does this answer your question?
Doctor, if the ferritin is high, could I give erythropoietin?
Usually the answer is yes, because this is reactionary. This is not necessarily a high ferritin with the chronic renal failure and the chronic inflammatory bowel disease. But what you can do in this case, you can give the first few doses of erythropoietin without iron and check the ferritin again. If the ferritin goes down, start ferritin.
Thank you, Doctor.
ممنون. You're welcome. Any other question? All your questions are clever, and it indicates that you have absorbed what we have said earlier. So let's go to part 2 of this presentation. Next slide, please. Polycythemia. Okay, polycythemia is the opposite of anemia. Okay, and in a man, polycythemia is defined as hemoglobin more than 18.5 and hematocrit more than 52%. And in a woman, polycythemia is a hemoglobin of 16.5 and more, and hematocrit 48 and more. But if you get a single blood count, which tells you that the patient is polycythemic, repeat the test, because often there is reactionary polycythemia, and it has to be, you shouldn't label your patient as polycythemic unless you have 2 to 3 blood readings showing polycythemias. Next, please. Causes. The causes of polycythemia could be primary, and this is called polycythemia rubra vera, okay, and it could be secondary. The primary polycythemia rubra vera is not very rare, actually. Is a disease which you can see every now and then. Very often present with itching, because a high serum iron can cause itching, and I remember many cases referred from the dermatology clinic or seen in the dermatology clinic, and they proved to be polycythemic. Splenomegaly present in about 75% to 3/4 of patients as a palpable spleen. This doesn't occur with secondary polycythemia. So splenomegaly in the presence of polycythemia indicates that this is a primary polycythemia, i.e. polycythemia rubra vera. The white blood cells and the platelets and the uric acid, all of them are usually high with polycythemia rubra vera, primary polycythemia, and they are usually normal in secondary polycythemia. The commonest cause of secondary polycythemia is COPD, chronic obstructive pulmonary disease due to smoking. Okay, here you test the oxygen, and you will see that the oxygen saturation is low. You should check the oxygen saturation at rest and after exercise. Obese patients with sleep apnea syndrome, most of them are polycythemic. And sometimes polycythemia occurs with renal tumor, whether benign or malignant, because renal tumors often secrete erythropoietin. And if you remember, we said this early, and you remember your physiology, erythropoietin is the hormone which is responsible for stimulating the bone marrow to synthesize red blood corpuscles. Next slide, please. Yeah. What blood test do you do in polycythemia? First of all, check the erythropoietin, and in polycythemia rubra vera, the erythropoietin is low. It is raised with COPD, and it's raised with renal tumors. Okay, I will say it again. The erythropoietin is a very important differentiating test with polycythemia. With the primary polycythemia, the erythropoietin is low. This is just like the thyroid stimulating hormone in primary hyperthyroidism. In primary hyperthyroidism, you will see that the hormone is low because the defect in the gland itself, not higher up. Okay? And in polycythemia and COPD, it is high, and in renal tumors, because there is excretion or secretion of the hormone, it's high as well. Okay. JAK2 mutation test is, if available, is diagnostic of polycythemia, and it should always be carried on. This is due to mutations. 95% of polycythemia rubra vera. This test is high. And it's normal with other causes of polycythemia. Next slide, please. Neutrophilia. When the neutrophils are high, this is again, remember that all these indices can be seen on the complete blood picture. We are discussing the complete blood picture. If you remember the first slide we have seen, there is white blood cells, RBCs, etc. And in the white blood cells, the neutrophils, lymphocytes, etc. So if you find that the neutrophils are high, what is the possible causes? The commonest is infection, tonsillitis, pneumonia, lymphadenitis, etc., and inflammation. Malignancy is another cause. Myeloproliferative diseases is another cause. Polycythemia rubra vera, but not secondary. Primary polycythemia. Steroid treatment can cause this, and chronic myeloid leukemia, of course. Chronic myeloid leukemia. Next slide, please. And this is what you see in a neutrophilia. Many neutrophils on a blood film. Okay? The one on the left-hand side of the slide is reactive neutrophilia. Reactive means secondary to inflammation, say tonsillitis or pneumonia. The one on the right-hand side is chronic myeloid leukemia. Next slide, please. Eosinophilia, often you find isolated eosinophilia. Only the eosinophils in the complete blood film is high, complete blood picture. And as I said earlier, please remember the first slide you have seen. If you find only the eosinophils are high, this is eosinophilia. And common causes of this are drugs. Some drugs can increase, particularly antihelminthic drug. Okay, and allergy like asthma, eczema, urticaria, parasitic infection. Okay, and the slide down below shows the eosinophil. Less common causes are chronic connective tissue disease, some skin diseases like pemphigus, and some malignancies like Hodgkin disease and sarcoidosis. Next slide, please. This is another case study number 5, a 75-year-old Caucasian male on routine full blood count. He was found to have a hemoglobin of 14. Okay, this is almost normal, but the white blood cells is 20. What about this blood cell? This is high, but not very high, but it is high. Neutrophils 5, lymphocytes 15, platelets 300, again with the normal, and there are mature lymphocytes. So this patient who's 75 is having a high white blood cells, but they are mature. If they are immature, they will be highly suggestive of lymphoblastic leukemia. No, these are mature, but the white cell is high. So this is probably a chronic lymphocytic leukemia, CLL. And as I have said earlier, we call it lymphocytic, chronic lymphocytic. We don't call it lymphoblastic because most of the cells, most of the lymphocytes are mature lymphocytes, okay? And you can see that in this particular patient, the hemoglobin is 14. So it hasn't affected the bone marrow very much. The hemoglobin is with the normal limits. In most anemias, other acute anemias, the hemoglobin is low. Okay. Next slide, please. Likely diagnosis, yes, chronic lymphocytic leukemia. What physical signs will you look for? I will look for lymphadenopathy. I'll examine all groups of lymph nodes. I'll examine the spleen. I'll examine the liver. The spleen, the liver, the lymph nodes, bone marrow, we call these reticuloendothelial system. What additional tests will you do? I'll do immunoglobulins, direct antiglobulin test, beta-2 microglobulin, phenotyping, cytogenetics, and sometimes you do bone marrow as well. But bone marrow is not always necessary in a chronic lymphocytic leukemia. If you ask me, if I see this patient, the white cell is 20, and I will ask him, I will reassure him, I will say, you have a problem with your blood, but it's not a serious problem. And let us repeat the test after 2 months. Okay. And after 2 months, probably I'll find the same results. So I'll reassure him. I say, the lymphocytes are a little high, but they are not affecting the function of your bone marrow, and you are still in a good shape. Go and come back to see me in 4 months. And then in 4 months, probably I'll keep seeing the patient 3 times a year. Each time I do a complete blood picture. And as far as the patient is stable and his complete blood picture is stable, I leave him without a treatment. But if one of the complication occurs, then I will need to go in and interfere. Next slide, please. Lymphocytosis, yes. So this patient has lymphocytosis. Causes could be viral. And if it is viral, when I see the patient after 2 months, then I will see that the lymphocyte count has dropped down to normal. So if it drops down to normal after 2 months, I will assume that probably it was a viral infection. If it remains high, then it could be leukemia. Okay. A blood film is done. A blood film is not difficult. Okay, but the bone marrow is not indicated because the bone marrow is more, more difficult to do. Okay, more infiltrative. Lymphoproliferative disorders like CLL, yes, is the likely diagnosis in this patient. Because of the age of the patient, he is 75. Look for enlarged lymph nodes or spleen, as we said earlier, and the diagnosis in this particular case was lymphoma and hairy cell leukemia. You know, lymphoma and the chronic lymphocytic leukemia are not too far away from each other. Okay, and many cases of the lymphoma ultimately will end into lymphocytic leukemia. Next slide, please. Yes, this is a slide showing lymphocytosis. Okay, this is reactive lymphocytosis, multiple lymphocytes in the field. Next slide, please. This is another slide showing lymphoma, and the one on the right-hand side is hairy cell leukemia. Next slide. These are difficult for you. You are not responsible to, supposed to know these. Case study, 40-year-old Afro-Caribbean male on routine full blood count, his hemoglobin was found to be 14, the white cell 2.8, neutrophils 1, platelets 300. Okay, so what's wrong with this patient? What's wrong with this patient is the white cell count is low, 2.8. Not very low, but it's low. But the hemoglobin is normal, and the platelet is normal. Okay, so this is unlikely to be a problem like leukemia, because you may ask here, can we find a low blood count, a low white cell count with leukemia? The answer is yes. The white cell count in leukemia is usually high, but sometimes it's normal or low, and this is called subleukemic leukemia. Okay, the points of relevance in the history, is the fact that he is Afro-Caribbean. Okay, this is common in this area. It's a benign condition, just low white blood cells. With each viral infection, it go even lower, and they are prone for repeated viral infections. But this condition is compatible with long life, and usually it requires treatment only during infections. I have seen cases of this among Iraqi patients, and I have seen cases among this in Jordan as well. Although it's called Afro-Caribbean, this condition is rare in Europe. Yes. Usually there is no enlargement of the spleen, no enlargement of the liver, no lymphadenopathy. Okay, and this is called, what you see the name here at the end of the slide, the bottom of the slide, benign ethnic neutropenia. Ethnic means لها علاقة بجنس بالعنصر, as we said early, and as it's written in this slide, it's Afro-Caribbean, but I'll say it again. I have seen it in Iraq and I have seen it in Jordan. Next slide, please. A neutropenia, when yes, this is benign ethnic Afro-Caribbean infections. They are prone for infections, particularly viral infection, and when the infection subsides, the count will go back to its normal 2.8. So if this patient develops, and I used to have patients like this, exactly 2.8, his normal white blood cell, with each infection, her blood count goes down to 0.5 or to 1. And in this case, we isolate the patient to protect her from secondary infection, give appropriate antibiotics, and wait until the infection is over, and the white cell blood count will go higher. Yeah. Bone marrow sometimes is needed. Make sure to check the B12, because if you remember, I said earlier, B12 can cause low hemoglobin, low platelet, and low white blood cells. Immune diseases, particularly SLE, can cause this problem, and rheumatoid arthritis as well. Filtes syndrome, which is a type of rheumatoid arthritis associated. Filtes is rheumatoid associated with splenomegaly, and the white cell count may go down in this particular condition. Next slide, please. The lymphopenia, when the lymphocytes are low, a common cause, or probably on the top of the list, is SLE, systemic lupus, erythematosus, rheumatoid arthritis, HIV, secondary to chemotherapy, malignancies, particularly Hodgkin disease, and sarcoidosis. These are the commonest causes of low lymphocyte count on the complete blood picture. Remember that we are still in the complete blood picture. All the information we have here today is how to read the CBC. Next slide, please.
الليمفوبينيا من ضمنها كوفيد هماتين يعني.
الكوفيد اي نعم. This is another case, a 35-year-old Caucasian female. She complains of joint pain. Her hemoglobin is 12, the white cell is 4 neutros, 2 platelets 80. So the platelet is low. You see the platelet count is low. MPV 12, cisplatin, possible diagnosis, rheumatoid arthritis, SLA, or immune ITP, autoimmune or immune thrombocytopenic purpura. Drugs can cause this picture, and HIV can cause this picture, but let us further the study and investigation of this patient. So go to next slide, please. Yeah, this is thrombocytopenia, low platelet count, isolated drugs. And how do we know about the drugs? By appropriate history. So the history is important. What drugs exactly this patient is taking? Remember that alcohol is an important cause. Alcohol is a drug. And in my experience, the commonest drug causes low platelet is alcohol. Yeah. If there is no if all are excluded, and examination of the patient for lymphadenopathy, spleen, liver, all negative, then the diagnosis is ITP, autoimmune or immune, the new name for it, immune thrombocytopenic purpura. The patients usually present with purpura mainly on the lower limbs, on both legs. Usually the purpura is symmetrical, and when severe it goes higher up, but it starts down in the legs and it ascends up. Okay. It could be secondary to SLE and some other rheumatological condition. I have seen cases of ITP present as immune thrombocytopenia, and years later, other manifestations of SLE, systemic lupus erythematosus, will develop. So the diagnosis was from the first place low platelet due to SLE. Yes. HIV, human immune deficiency syndrome, is another cause. Liver disease, chronic liver disease, when they cause portal hypertension. Not without portal hypertension, with portal because with portal hypertension, the spleen will go bigger. And when the spleen is bigger in size, then more platelet will be destroyed. The function of the spleen is to remove the diseased or the deformed platelets. So the blood passes through the spleen, and the spleen will filter the blood. If the spleen is bigger in size, it will filter more platelets, and the platelet count will go down. And any patient, sometimes a car accident will cause rupture of the spleen, and the surgeon will go on and remove the spleen. You will see that these patients will always have a high platelet count. And splenectomy is one option in the treatment of ITP. Alcohol, I have said this, please don't forget this. When I was in Ramadi a few months ago, I did talk about alcohol, hepatitis, and I did say that we used to have alcohol unit in North London, and one of the very important tests I used to look in to tell whether the patient is still drinking or not is the platelet count. The patient may come in the clinic after abstinence or after drying down, and he say, I don't drink alcohol. Then I'll see that his platelet count is low. I'll say to him, but your blood test is telling another story. This means I'm not believing you. And he'll say, oh, doctor, I've been with a friend. Yes, recently I started drinking again. So believe me, the low platelet count almost always occur with alcoholism. Alcohol is a direct toxic drug, to the bone marrow. And as you know, the platelet has a short survival, 5 to 7 days. That's why the first component of the bone marrow to be affected are the platelets. And when the patient abstinates, stops drinking alcohol, within a week, the platelet count will go back to normal. Yes. Next slide, please.
دكتور بس هنا السؤال بلا زحمة. دكتور الاي تي احنا قلنا عليه اذا الاميون thrombocytopenic purpura the best therapy is splenectomy.
لا, the first treatment is with corticosteroids. Yeah.
Okay.
First of all, you have to exclude, do a blood film, make sure that it is not leukemia, check the anti-nuclear antibody. If the anti-nuclear antibody is negative, then it is very unlikely to be SLE, systemic lupus. After that, the treatment is corticosteroid. I myself usually give prednisolone 20 milligram twice daily, i.e. 40 milligram of prednisolone daily for about 2 weeks, and then start tapering the dose. You will see that after 1 week, the platelet will go back to normal because, as I said earlier, the platelet half-life is short, 5 to 7 days. So if you give corticosteroid, within a week, the platelet count will go back to normal. Then start reducing the dose gradually. And go on with the corticosteroid for about 2 months. If you see that you need longer period of time, you can, to avoid the side effects of a steroid, you can, in this case, add azathioprine in a dose of 50 to 100 milligram. This is a steroid-sparing drug. So you reduce the dose of a steroid and you add azathioprine. And you may need to continue for about 2 years on this. Okay, sometime, but not, what I meant is the 2 years follow-up. But after a few months, you titrate the dose down. Of course, you do repeated complete blood pictures, okay, and you maintain the patient with a normal platelet. You discharge him, and then you see him frequently in the clinic. About 35% of the patient will not have a relapse, and that's it. But some of them will relapse again. In this case, you go again and give corticosteroid and azathioprine. If they relapse for the second time, consider splenectomy. And splenectomy is very effective. Okay, the spleen will not treat the disease. I mean, you know what's the disease in ITP. If this is the platelet, in ITP, there is an antigen sitting on the platelet. And when this platelet passes through the spleen will recognize the antigen and it will destroy the platelets. Okay, so when you do splenectomy, the antigen is there on the platelet, but there is no spleen to destroy the platelet, and the platelet count will go back to normal. But in these cases, they will be prone for some types of infection, particularly pneumococcal, and you must vaccinate them with the pneumococcal vaccine, and you see the patient frequently. Okay, hyperimmune globulin is another way of treating ITP, but in my experience, I usually treat this way: steroid for the first time. I will say it again, and after 3 or 4 months, I stop the steroid gradually, of course, and wait for the patient, and then if they don't relapse, if they remain in remission, fair enough. If they relapse, I will go with another cycle of corticosteroid. If they relapse again, I will consider splenectomy. Okay, Muhammad?
Okay, thank you so much.
You're welcome. Okay, next slide, please. How do we investigate thrombocytopenia? We have said some of this anti-nuclear antibody to exclude SLE. You know, this is a very good screening test for systemic lupus. 98% of systemic lupus patients have a positive anti-nuclear antibody. So if you find it positive, it may indicate SLE, but it may indicate something else, like rheumatoid arthritis. In old people, sometimes it's positive without any disease. So in this case, you have to do other investigation for SLE. This needs a separate lecture. You may need to, particularly in females, to do anti-phospholipid test. You do HIV test. You investigate the liver, as we said earlier. And again, as I have said earlier, please don't forget to check the B12 and folate. Again, in my experience, B12 deficiency as a cause of thrombocytopenia is much more common than folic acid deficiency, although in textbook they put them together. But I will say it again, in my experience, B12 is much commoner cause. Next slide, please. Thrombocytopenia and pregnancy. This is gestational, usually mild, occurs mainly in the second and third trimester, sometimes associated with hypertension, PIH, but autoimmune thrombocytopenia is possible in some cases. And HIV patients, remember that patients with HIV, they can't get pregnant usually. And if the history is suggestive, suitable test should be done for HIV. Next, please. Thrombocytosis, yes. ITP is much more common than thrombocytosis. ITP is low platelet. This one is high platelet, okay? And this could be primary or it could be reactive. Reactive, we have said this, infection, inflammation, and in this case, you'll find that the ESR and CRP, C-reactive protein, you'll find them high. In malignancy, you find it high. Remember, I did say that in iron deficiency and with bleeding, the platelet count will go high. And actually, if you remember the second slide I have showed, the platelet was, if I remember well, 800 plus. And I did say that this is suggestive of iron deficiency or bleeding. Post-splenectomy, yes, we just discussed that the spleen, post-splenectomy, the platelet count will go higher, but there is a primary thrombocythemia, primary thrombocythemia. This may be associated with polycythemia rubra vera, and I did tell you earlier that polycythemia rubra vera or primary polycythemia differ from secondary polycythemia by the fact that in a primary polycythemia, the hemoglobin, the white cell, the platelet, all of them are high, while in secondary polycythemia, only the hemoglobin is high. Okay, but it is not always polycythemia rubra vera. It can be just thrombocythemia, although these conditions may intermingle together. Myelofibrosis is another cause, and in this case, the spleen is usually enlarged. Chronic myeloid leukemia is another cause, of course, and in this case, the hemoglobin is low, the white cell count is high, and the spleen is usually enlarged. If you decide at the end of the day that this is thrombocythemia, then if it is mild, it should be left without a treatment, but you must observe the patient for complications, and the complications are usually thrombosis in the extremities or central. If the platelet is very high, then hydroxyurea is a drug which gives very good results. I have some experience with it, treated a few patients, and usually they respond pretty well. Next slide, please. 70-year-old Caucasian female complaining of back pain. Her full blood count is normal, urea and electrolytes normal. Her liver function tests show raised globulin 42, protein electrophoresis showed IgG, paraproteins 5, other IgS, A and M were normal. Possible diagnosis myeloma or benign MGUS. MGUS is monoclonal gammopathy of undetermined source, of undetermined significance. Okay, this is a benign condition. Usually you find on protein electrophoresis, we'll show some slides that that there is an increase in one of the components, but the others are normal. And this occurs in multiple myeloma, but in multiple myeloma, usually this is a severe disease. And in this condition, the hemoglobin is low, the blood urea is, in multiple myeloma, the blood urea is high, the calcium may be high. But in this condition, all these were normal. Normal hemoglobin, normal renal function, normal, except that there is gammopathy on the protein electrophoresis. And this condition needs just follow-up observation. Yes. Next slide, please. Raised globulin, often non-specific. Protein electrophoresis will show diffuse increase in gamma globulin. A diffuse increase indicates that it's probably secondary to infection or inflammation, or if it is only one of them is high, this is suggestive of multiple myeloma or of the benign gammopathy I have described to you. Yes. So protein electrophoresis is required, and this is protein electrophoresis. Okay. So I will say it again. If you find diffuse increase in the globulins, it means that it's an inflammatory or infectious process. If you find that only one is high and the others are normal, there are two possibilities. The first possibility is the monoclonal gammopathy of undetermined significance, MGUS. And in this condition, all other investigations are normal. Marrow is normal, the lymphadenopathy, no splenomegaly, the hemoglobin is normal, the other blood indices are normal. So this is a benign condition which needs a follow-up only and reassurance of the patient. But it is a major criteria for multiple myeloma, okay? And with multiple myeloma, other manifestations of the myeloma can be seen. Go to next slide, please. Okay, this is myeloma versus MGUS. Okay, I have discussed all of these, but I'll give you a few seconds to look into them. I did talk about hypercalcemias, Benz-Jones protein. Remember this Benz-Jones protein, another important criteria for multiple myeloma. And this protein, you know, when you put the urine in a test tube, this is the idea of this test. If you put the urine in a test tube and boil it or heat it, then the protein at a certain temperature will coagulate. If you keep heating, Benz-Jones protein will disappear, but a normal other types of protein will coagulate more. This is just like the white of an egg. The white of an egg at a temperature of 60 will coagulate. Okay. In multiple myeloma, you see bone pain and organ failure like anemia, increased creatinine, hypercalcemia, higher concentration of paraproteins, immune paraparesis. This can cause infection, Burns-Jones protein, lytic lesions on the X-ray, typical bone marrow findings, and I'll show you slides of what do I mean by typical bone marrow. Okay, and the benign condition, none of these are there. None of these are there. Go to next slide, please. Yes, this is the humerus of a patient with multiple myeloma, and this is on the right side the skull of a patient with multiple myeloma, multiple lytic lesions. Multiple lytic lesions. A single lytic lesion is not a major criteria, but two lytic lesions and more is a major criteria for multiple myeloma. The fracture in this humerus is not traumatic. This is pathological fracture due to the multiple myeloma. Next slide, please. Yes, this is a bone marrow for a patient with myeloma. You see, these are myeloma cells. And when myeloma cells are present in a concentration of 20% and more, it's a major criteria for multiple myeloma again, okay? So protein electrophoresis, X-ray of skull and big bones, and bone marrow, plus the usual complete blood picture and biochemistry of the blood is the way you look into multiple myeloma. Yes. Next slide, please. Thank you very much. Yes. Any question?
Doctor, can you explain just in summary febrile neutropenia?
Febrile?
Febrile.
There is no such a term, but fever, in this case, indicate infection. And infection can cause this. Yes. Reactionary to fever, maybe, yes. But this is something which is usually, if you find it, then it indicates infection, fever and neutropenia. But neutropenia does not occur with each infection. It occurs mainly with viral infections and sometimes with, what shall I call, parasitic infections, etc. Yes. Any other question?
Oncology, يعني cases of oncology. يعني.
Okay, yes. With malignancies, it can occur. Most malignancies, for example, if we will have time for lymphoma, we may discuss this. We stage them, stage 1, 2, 3, 4, A and B. A means that there is no fever. B, there is fever, and each one indicates something. If one day, I mean, this needs a separate lecture. Any other question?
دكتور patient ما أعرف أنا بس CBC يعني ال complete blood count أنا شفته مالته هو stroke يعني مثلا patient right sided weakness come with right side weakness stroke, okay, and with expressive aphasia, but the CBC was hemoglobin was 6. And yes, and platelet was, I think, 700.
Yes. What else?
And the MCV microcytic and the serum ferritin low confirmed iron deficiency anemia. But the question, if you have thrombocytosis and the patient unstable,
yes,
with low hemoglobin 6 and need transfusion, if I give better, I give packed RBC. Is that true?
It depends on when the patient. No, it depends on the condition of the patient and what the patient has lost. In accidents and surgery, it is better to give whole blood because the patient will not lose RBC. I know this often in surgery, this mistake is done. The patient after a trauma will lose whole blood. So you better give whole blood. In medicine, particularly if the patient is in heart failure and there is no hypovolemia, but you may think that a transfusion, and this is of course correct, the transfusion may push the patient into heart failure or acute pulmonary edema, then in this case, you better give packed red cells, okay? If packed red cells are not available, you can give blood slowly and give diuretics along with it.
Okay. Doctor, my question, the thrombocytosis in this case is not contraindication for whole blood transfusion if I need it?
No, it's not a contraindication, no.
Oh, okay. Thank you, sir.
Welcome. Okay, Mohammed.